The subcommittee will come to order. Good afternoon. Since we had a later start than originally anticipated, let's go ahead and get started. For quite some time now, there has been a discussion around DC about moving the Medicare program toward a value-based system as opposed to the volume-based system that the traditional fee-for-service system has lived under for over 50 years. During the last 20 years, there has been some movement in this direction on a bipartisan basis, no less. A revamped Medicare Advantage program, a new prescription drug benefit in Medicare, and the start of Medicare's shared savings programs, known more colloquially today as accountable care organizations, or ACOs now, were each one additional step towards achieving higher value and coordinated care for our seniors. Fast forward to 3 years ago, when we passed the MACRA law that repealed the onerous sustainable growth rate, another legacy law of a different era that was creating undue yearly burdens on both our nation's clinicians and, in turn, patients. MACRA implementation is well underway, encouraging providers of all types to work together to reduce costs and to increase the quality, value, efficiency, and coordination of care steps further. However, there are certain laws that have long been in place to protect the program and patients, but now stand in the way of making real progress toward the goal of value over volume. Today, we are here to talk about the Physician Self-Referral Law, or Stark Law, and have an intuitive discussion as a first step towards what I know to be a needed modernization of the law. Stark laws were, and in many ways still are, necessary to ensure patient safety and a safeguard over taxpayer dollars. These laws essentially prevent physicians from making referrals to entities that provide certain services if they have any ownership or financial stake in that entity. Now, understandably, that is an oversimplification, particularly now that the web of regulations born out of the laws are nearly impossible to navigate without legal assistance. In a world where we are now pushing our providers to work closely together to bring down costs and, in many cases, share in the savings that they create, we need to update the laws to give providers an easing of burdens and give the Centers for Medicare and Medicaid Services more flexibility to supply waivers to these providers who do get into these high-value arrangements. For the sake of avoiding getting repetitive, I will say it just one more time. The goal here is shared by all: better care for Medicare patients. We will hear from the Department of Health and Human Services today, and then from providers who will share their knowledge and experience to set the table for what I hope will be an ongoing and robust discussion going into next year. Without objection, we are going to move to 4-minute member questions today in the interest of finishing up before votes. Without objection, so ordered. Let's get right to it. Let me just welcome the ranking member, Mr. Levin, for purposes of his opening statement.
Thank you very much. As I know firsthand, and as do my colleagues who worked with us together on healthcare reform, at the heart of ACA was a recognition that we must transform how we pay for and deliver healthcare in this country. The law gave providers tools to establish accountable care organizations, bundled payments, and other groundbreaking ways of paying for care. It also created the Center for Medicare and Medicaid Innovation, which tested many value-based payment models under the leadership of the Obama administration. These reforms have ushered in an evolution in healthcare delivery that we are witnessing unfold every day in our districts. As we enter this new landscape, we have begun to hear calls to revisit certain other laws that have been in existence for many years. Today, we are discussing whether several laws that prohibit physician self-referrals in Medicare, collectively known as the Stark Law, with whom a number of us served, should be re-examined in the light of our shift to a value-based payment system. On this issue, we must proceed with care. The Stark Law is an important tool that for nearly 30 years has protected Medicare beneficiaries from inappropriate referrals and overutilization of care. Despite its complexity, the core principle of the law is a simple one. The physicians should not make referrals to entities in which they or an immediate family member have a financial interest. Evidence continues to document that these self-referrals have a detrimental impact on care. For example, a series of reports by the Government Accountability Office found that an exemption in the law permitting self-referrals for in-office ancillary services has directly increased overutilization and raised Medicare spending by billions of dollars. However, the incentives that existed in a fee-for-service healthcare system are not the same as those in a value-based system. Integration of care may, in certain instances, involve financial arrangements that do not violate the basic spirit of the Stark Law. We recognize this fact when we passed the Affordable Care Act, providing waiver authority to allow for providers to establish ACOs and other arrangements. In addition, the Obama administration provided leeway through the regulatory process to facilitate new payment models. More recently, an ongoing request for information will provide additional information as to what may be done using existing statutory authority. Before considering legislative action, I hope that this committee will proceed with a process that befits an issue of such sensitivity and complexity. Unfortunately, no witnesses from the Office of the Inspector General or the Department of Justice were invited by the majority to join this afternoon. It is critical that it be corrected soon. Finally, it is ironical that this subcommittee is considering the impact of the Stark Law on the value-based approach of the ACA at the same time the Trump administration continues to raise costs and reduce access to health care in its never-ending zeal to sabotage the law. In the last few weeks, it has refused to defend protections for Americans with pre-existing conditions, stop risk adjustment payments to health plans covering sicker patients, and again slash payments to the navigators that help people access health insurance. These and many other misguided efforts are raising costs for those Americans who need health care the most. We should be examining and responding to this growing threat to affordable health care. Instead, this subcommittee has exacerbated it through its silence in the face of regulatory sabotage and its own legislative efforts to rip coverage away from millions of Americans. I yield back.
Without objection, other members' opening statements will be made a part of the record. I'd like to introduce our first witness today, as we're fortunate to have him, as he is leading the administration's efforts to modernize the Stark laws on the regulatory front. Eric Hargan, Deputy Secretary of the Department of Health and Human Services. Thank you for being here, and you may begin for your testimony.
Mr. Smith, Ranking Member Levin, it's great to be here today. As many of you here know, Secretary Azar has outlined 4 priorities for HHS: reforming the individual market for health insurance, lowering the price of prescription drugs, taking on the opioid crisis, and putting in place a healthcare system that emphasizes value and outcomes over procedures and spending. The aim of all of these priorities is to provide quality care for the American people. Regulations, especially ones like the Physician Self-Referral Law, commonly referred to as the Stark Law, can hinder the development of newer and better ways to help Americans live healthier. These regulations affect at least 1/6 of the economy, and just as important, often directly affect family doctors and nurses who consult with us during some of life's most challenging moments. HHS is determined to give healthcare providers space, not just to provide quality care and to really listen to patients, but to innovate as well. When enacted in 1989, the Stark Law rightfully addressed the concern that inappropriate motives could distort decision-making in healthcare. It recognized a worry that some physicians might order services based on their financial interest in service providers rather than the good of their patients. And in a largely fee-for-service context, this made sense. Congress intended to protect the American people and the Medicare program from abuse. The law did it in two specific ways. First, it banned doctors from referring patients for certain designated health services payable by Medicare to an entity in which the physician or any immediate family member holds a financial relationship. Second, it prohibited the entity from filing claims with Medicare or billing another individual, entity, or third-party payer for those referred services. These restrictions are absolute, with certain enumerated exceptions, and the law grants HHS the authority to carve out exceptions for financial relationships that do not pose a risk of program or patient abuse. But what made sense for the healthcare system of the 1980s does not necessarily translate to the modern healthcare system. The President's budget called for a modernization of the Stark Law. That's why last month I asked the Centers for Medicare and Medicaid Services to take the lead on the task of re-examining the Stark Law by issuing a request for information to obtain public input on ways to address any undue impacts and burdens that the law causes. The Stark Law, which, as I noted, is designed for a fee-for-service model, does not always work in a system transitioning and moving to value-based payments for health care. It may unduly limit ways that physicians and healthcare providers can coordinate patient care by restricting ways that physicians can organize and work together and with others. In considering changes to the Stark Law, we must be cognizant of the need to preserve competition in the healthcare marketplace where such competition achieves the goal of patient-centered quality care while also controlling costs. So we have asked CMS to consider input from stakeholders and to focus on how the Stark Law may impede care coordination, which is a key aspect of systems that deliver value. Through a request for information published toward the end of June, CMS requested additional feedback from stakeholders and the public on the structure of arrangements between parties that participate in alternative payment models or other novel financial arrangements, as well as the need for revisions or additions to exceptions to the Stark Law. HHS is also looking at the anti-kickback statute and its intersection with the Stark Law to see if either law or the interactions between the two is stifling innovative arrangements that could result in better outcomes for patients. Throughout this process, we will be consulting with our enforcement partners in the HHS Office of the Inspector General and the Department of Justice. As shown by the President's budget request and the range of information sought from the healthcare community in the Stark Law request for information last month, the Department is open-minded about the types of changes that may be needed to make the Stark Law more compatible with the push toward integrated care and alternative payment models. HHS looks forward to working with this subcommittee to find the best path to modernization, and I personally am looking forward to discussing the Stark Law today and working with this committee to find a balanced way that leads to coordinated care and better outcomes for American patients. So again, thank you for having me here today. I look forward to discussing the issue and taking your questions.
Thank you. Thank you for sharing your perspective and insight. We'll now proceed to the question and answer session, and I'll begin by recognizing Mr. Johnson from Texas.
Thank you. Thank you, Mr. Chairman. You know, this hearing is focused on finding ways to modernize the Stark Law. And as I'm sure you know, Obamacare effectively bans the expansion of physician-owned hospitals as well as bans the construction of new ones. This means Obamacare is preventing some of our best hospitals from expanding so that they can better serve our communities. And I think you agree with me that's just wrong. Deputy Secretary Hargan, would you agree that the Obamacare ban on physician-owned hospitals limits competition, yes or no?
Mr. Johnson, obviously HHS has to enforce the law the ACA put in place, which was a ban on physician-owned hospitals, the expansion of them, the construction of new ones. Obviously, prohibiting any new entrant into the healthcare marketplace is going to reduce competition. It's going to make sure that there aren't as many hospitals, many places for patients to go.
Well, thank you. And would you agree that physician-owned hospitals are some of our nation's best quality hospitals, yes or no?
I believe surveys have shown that physician-owned hospitals have good results.
wouldn't you agree that this ban is wrong? I think you just said it, and unfair. I strongly believe that expanding physician-owned hospitals can increase patient access to affordable quality health care. And will you commit to working with us to address the Obamacare ban on these hospitals, yes or no?
The department stands ready to providing the technical assistance that the subcommittee needs.
Thank you, sir. As this committee moves to modernize the Stark Law, I hope that in doing so, we once and for all address the unfair Obamacare ban on physician-owned hospitals. And I hope you agree with me. I yield back.
Mr. Levin.
Welcome. And I think your testimony is sensitive to the issue, and I think your answer to our distinguished colleague from Texas also was appropriately cautious. The issue of physician-owned hospitals has been a controversial one, and there were major abuses and problems. And I think your willingness to give technical assistance was well said. Let me ask you, in view of your position in HHS, I want to ask you, because we're not going to have any other opportunity, to ask about the stopping of the risk adjustment payments. That follows a decision, it was taken by one court in February. Now, 5 months later, we have this action that is rippling through healthcare and the industry and threatens people with their payments. Could you please tell us, within your knowledge, who was responsible for making that decision?
Yes, the department filed a motion for reconsideration with the court after the court made a decision to prohibit the risk adjustment that the department had put in place. In late June, the court ruled against that, and so at that point, HHS had to make sure that the provider community was aware that the court had imposed what turned out to be a nationwide ban on the risk adjustment. The court's decision was not limited to New Mexico, which is where the court sits, but was applicable nationally. And so the risk adjustment that had been undertaken had to be, obviously, we had to obey the court order, and that means that we had to make sure that the provider community knew that the court's decision was standing as of that time.
Did you, HHS, consult the White House on that?
I can find out about the ins and outs and get back to you, sir.
Could you not issue immediately an interim rule so that payments could continue? Don't you have that power?
We are looking at all kinds of potential responses to the court's decision that obviously vacated our rule on that part of our risk adjustment. So we're taking a look at all kinds of different options.
You had 5 months. Why weren't you looking at those options before you issued this policy change that threatens dramatic change? Why didn't you take that time? It's a real problem, isn't it?
It is a real problem for some parts of the healthcare community, yes.
Okay, so why all of a sudden, after 5 months, you act when you didn't take action during those 5 months to try to rectify the situation? I don't understand it, and the public doesn't understand it, and the industry doesn't understand it.
Yeah, as I noted, sir, we were undertaking to convince the court through a motion for reconsideration to go back and reconsider its decision on that. Ultimately, the court decided to reaffirm the decision it had originally gone with. And so at that point, we had to, in the interest of prudence, make sure that we alerted the provider community that the court's decision was standing, and
You can do two things at once, you know.
Gentleman's time has expired. Mr. Nunes?
Thank you, Mr. Chairman. Deputy Secretary, welcome. Just have one question for you. As we look for ways to modernize Medicare, I know that you're trying to do the same, as Congress has struggled with this for many years. And healthcare continues to shift from fee-for-service to value-based care. And I'm interested in the thoughts that you may have, if you could kind of lay out just maybe 1, 2, and 3 concepts or ideas on changes to the Stark Law and how that would help Medicare beneficiaries.
Yeah. So changes to the Stark Law, as I mentioned, the kind of Stark Law now is, although fee-for-service is still definitely a part of the healthcare landscape, and so the Stark Law still does its work on that part of the healthcare system. Right now, we still have a majority of the system that's in fee-for-service. However, the transition to value-based care, the Stark Law is already, in many cases, as we hear from our stakeholders, is standing in the way, creating friction about the move to value-based care. Some of the things that we've heard about is already from stakeholder engagement on this front is that they believe that it's standing in the way of innovative models of care coordination, providing incentives between doctors and hospitals that could be very valuable, that are going to enable better quality patient care so that patients aren't required on their own to coordinate their own care between them and their loved ones. And the Stark Law, in many ways, can prohibit models or discourage models of coordinated care that would enable that.
Those models would be models that would include new technology,
exactly,
being able to telemedicine, things of that nature.
There are many elements to that. In other words, the Stark Law applies very broadly with regard to physicians. So anyone a physician could interact with, whether it is a medical product provider like a device, dealing with devices, whether it's a hospital or really anyone in the system could be subject to the Stark Law and to the effect that it has on the ability of physicians to coordinate care and of patients to receive coordinated care.
Well, I encourage you to do all you can, and I hope, Mr. Chairman, that we can act as soon as possible. And I yield back.
Thank you. Mr. Thompson.
Thank you. Thank you, sir, for being here today. Last week we had a markup in our committee, and we spent a lot of time and were able to discuss a number of the things that the majority party and the administration are doing to undermine the current health care law and to sabotage the Affordable Care Act. According to PricewaterhouseCoopers, Republicans are going to be responsible for as much as a 24% overall rate hike in health care. Many of us raise the issue of efforts to discriminate against our constituents who have pre-existing conditions, and the administration has been front and center in this effort. You've expanded access to junk health care policies that don't cover essential benefits, charging more for pre-existing conditions, charging more for older people for their health care. And this is going to have an effect where millions of people are going to be hurt and leave the individual market and provide will not be able to spread the risk out. So we're going to have sicker people trying to get coverage, and it's going to be a real disaster. And I think this is a problem that we need to deal with. One of the things that's happened that I have concerns with is the cut in the millions of dollars in cuts for enrollment grants that have taken place this year. And we know that this type of grant system helps. We have good evidence in California where they've been able to expand the market, they've been able to drive down the price, and they have lower premiums this year by 3%, and that's better for everyone. And the monies that you're cutting aren't even they're not general fund monies. These are monies that are paid for by user fees. Can you tell us how much of these user fees you're going to collect this year?
I can get that information back to you, sir.
So you don't know what that number is? Does $1 billion sound close?
We can get back to you with the exact information.
Well, the number that I've heard is roughly $1 billion in the fees that you're collecting, but you're not spending much of them. About $870 million of that billion won't be spent. Is that correct?
Sir, we can get back to you with that information.
So the difference between whatever you collect and what's being funded after the cuts will not be spent, right? That's not, you don't have to get back to me for that information. That's just a fact. If you collect it but don't spend it, you're going to have money in reserve.
That sounds logical to me.
What are you going to do with that money?
I will get back to you with any information about the user fee and how much is being spent.
When can we expect that? About $870 million, and we have no idea what you're doing with it. When can I expect to hear from you as to where those dollars are going?
We'll get back to you as expeditiously as possible.
Thank you. Yield back.
Mr. Buchanan.
Thank you, Mr. Secretary. Thank you for being here today. Let me ask you quickly, when you look at the Starks law and anti-kickback law, how do you compare the difference, the overlap, just as from a general educational standpoint? How do you define the difference, and then do they work together on certain scenarios, I should say?
Yep. There is the two laws do not necessarily act in concert. They address a lot of the same issues, but they don't act together. They're overseen by different parts of HHS, Centers for Medicare and Medicaid Services in the case of the Stark Law, and the Office of the Inspector General with regard to the anti-kickback statute. They have significant differences in that one is really oriented on sort of civil penalties. One is a criminal statute dealing with intent. One is a strict liability statute where, you know, if you violate the law, you're done in a sense, because if you violated it, you don't get to prove whether you had a good intent or a bad intent in doing so. So the two laws have, in the Stark Law, you have exceptions created by CMS. In the case of the anti-kickback statute, you have safe harbors by the Inspector General. Even though in many cases they cover the same general areas, they're worded in different ways. They haven't been coordinated over time, and so it leads to a situation where the provider community that's trying to create a system of coordinated care really finds it very difficult, if not impossible, to understand the why and wherefores of why these two systems are operating so differently over the same exact area. So
let me ask you also, just in terms of, at least in our region, but I think across the country, and I'm not saying the last 7 years, but my experience the last 20 years, the huge rising cost in healthcare in general for a family of four. The Stark Law was put in place in 1999. I'm not sure on the other law, but by modernizing or looking at them, will that do anything to help lower cost in general? Because I can just tell you, people are drowning in the cost of healthcare today. And again, this isn't something in the last couple of years. This has been going on for 20 years. I've seen it as a business person. So what might it do, or what can we expect that might happen?
Yeah. Well, we've articulated value-based care as one of the cornerstones of what we're going to be driving towards. That's something that has been a goal of past administrations as well. One of the cornerstones of value-based care that we see is coordinated care. And to be able to coordinate care, we need to modernize Stark and the interrelation between the Stark and the anti-kickback laws. And so we anticipate, because we're going to be able to allow more coordinated care, we'll both get better quality care and, we believe, a lower cost. When we allow there to be more different models of coordination, that means that we'll be able to allow there to be more experimentation, innovation.
Let me ask you one more, time's running out, one more question. Just in our region, in Florida, Sarasota region, there's a lot of consolidation with hospitals and others buying up practices. I'm not saying it's good or bad, but how does this impact these laws? Because lots changed in 20 years or so.
Yep. we have heard back from stakeholders that the consolidation in the provider community in many cases is being driven by considerations of the Stark Law. And so in other words, the law is actually driving a lot of the business transactions and the consolidation that's happening in the industry. Now that itself, the fact that we're a regulation that's intended to have physician self-referral and prohibit that is actually driving the way that we're structuring the entire industry and driving patterns of consolidation that I'm not sure was intended.
Thank you. Yield back.
Mr. Kind.
Thank you, Mr. Chairman. Mr. Hargan, thank you for testifying here today. Last fall, Mr. Marchant and I had teamed up to offer a stark simplification law to try to further clarify and define what constitute technical violations and more egregious violations. It's made a part of the budget. You guys now are in charge of implementing. I was hoping to get a little feedback from your office as far as the implementation of that and how it's been working. Now, you've also been tasked to receive public feedback as far as what Stark Law changes need to be made, and I think we're all in agreement that with the move now towards greater care coordination, value, quality, outcome, the 89 Stark Law perhaps doesn't work so well in the modern era of where healthcare reform is going. And I'm confident that if our former colleague Pete Stark were here in front of us today, he'd admit the same thing, that we're in need of it. But we need to do this carefully so that we don't fall into the trap of self-dealing again out there, which was the whole premise behind Stark to begin with. But the question I want to ask you here today, and you can take a moment to think about it, is whether or not the administration is working on a Plan B on replacing the Affordable Care Act. You guys took a run at it with the complicity with the Republicans in Congress last year. You pulled up short. In fact, the bill that was before us under consideration would have driven up the uninsured by 25 million and would have given tax relief to big pharma companies and insurance companies to the tune of $800 billion. Thank God the American people knew what was trying to be pulled on them because they rejected it. And it was one of the reasons why it went down in Congress. And I don't know if the administration has a plan to try to resurrect that again at some point, or if you have a whole new plan that you're working on to replace the Affordable Care Act. Because from my perch and my perspective, all the efforts that the administration is doing to undermine the Affordable Care Act is leaving more and more Americans behind. Whether it was the elimination of the cost-sharing reduction payments, that's creating unhealthy insurance pools right now. You mentioned, Mr. Levine, the risk adjustment payments. I'm not aware of the administration coming to Congress with any proposed fix to that court decision, but that's something you could easily do by bringing that to our attention and saying this is what we need to do in order to fix that right now. But the elimination of the individual responsibility component, which was a part of their tax plan last year, is going to create, again, unhealthier markets. But don't take my word for it. Your former boss, Tom Price, the former HHS secretary, was quoted as saying, and I quote, "There are many, and I'm one of them, who believes that that will actually harm the pool in the exchange market because you'll likely have individuals who are younger and healthier not participating in that market, and consequently that drives up the cost for other folks within that market." And this is just self-evident. I mean, you don't have to be a rocket science to know that that was going to be the consequence of that short-sighted decision. But beyond that, today we're living in a country where, under this administration, 4 million more Americans are uninsured. And the premiums in the exchanges are going up. In Wisconsin, they're projected to go up by about $1,500. Again, directly related to the action that this administration and this Congress is taking to try to undermine it. So if the goal is to expand affordable quality health care coverage to more Americans, we've taken a drastic U-turn under this administration. And the one phone call that I took repeatedly last year in the midst of their repeal and replace effort were from young mothers with children with pre-existing conditions. They were scared out of their minds that their kids now were going to be left out there without adequate protection if they lose the protection of people with pre-existing conditions. And now this administration has joined a lawsuit challenging the constitutionality of that. I'm not sure where the politics are going to lie, but my guess is it's going to be scaring a lot of Americans where, well, more than half of Americans have what constitute a pre-existing condition in their life. So again, I ask you, is the administration working on a better Plan B, or are we stuck right now with this effort to just undermine the effects of the Affordable Care Act?
Gentleman's time has expired, so it's a rhetorical question. Mr. Smith?
Thank you, Mr. Chairman, and thank you, Mr. Hargan, for your presence here today. I think we have a great opportunity to work in a bipartisan fashion on these issues that you are addressing, and I hope we take advantage of that. I certainly appreciate your efforts to modernize the system. We know that we have some laws on the books that did not anticipate various technologies, and I would hope that we can, again, work together to address this so that we can help the American people. We heard a while back from ZocDoc, who explained that there are obstacles that stand in the way of adequately helping the American people. I know that representing a very rural constituency, issues can be a little different than more urban areas, and as services are rolled out and fee structures and so forth that might be required under existing regulations, that may not be the best business model to reach folks in more rural areas. And so we need flexibility. And when you look into the delays currently in place that stand in the way of patients receiving timely health care, I would hope, again, that we can work together to address this ultimately, I think, from certainly addressing regulations that are on the books, and I'm glad that already you and the administration are looking into that. But if you could perhaps elaborate, what is the administration's plan to account for the technological advances in healthcare relating to Stark Law and federal anti-kickback statute?
Yep. So first of all, I want to say that I'm also from a rural community, town of about 800, tip of southern Illinois, called Mounds. And I grew up underfoot in a rural hospital where my mother worked. So you can rest assured that we will have sensitivity towards the issues faced by rural healthcare providers at HHS. We take it into account. Obviously, there are a lot of challenges facing rural and remote healthcare providers that are unique to them. So we are, and again, the Stark and anti-kickback statutes also make it more difficult in many ways. It creates a special problem for areas where there are few providers that aren't actually connected with one another. In other words, when you only have one person that you can affiliate with in a community, it becomes a kind of a difficult issue to say, I can't affiliate with this person because the law prevents me from doing so. In other words, you can be driven to either remain completely isolated from anyone in the community because there are relatively few providers, or you're violating the law. So in other words, a rural community can be particularly afflicted by the Stark and anti-kickback statute as is often implemented. So that's a particular issue. With regard to, I believe you mentioned technological issues, in many cases the Stark and anti-kickback statutes create, again, a problem where people can't get access to technologies as quickly as they otherwise should be able to. And that is particularly an issue within rural communities because they often lag urban communities in being able to get access to technology as quickly and being able to implement it for the health of the people in those areas. So you have both lower quality of health, you have fewer providers, and you have more restrictions on them being able to coordinate with one another due to, in many cases, older regulations interpreting these laws.
Right, thank you. I yield back.
Ms. Sewell.
Thank you, Deputy Secretary, for being here today. I'm extremely interested in your personal testimony with respect to rural health, since I represent a district that has a hybrid. We have Birmingham, Alabama, which has some of the most sophisticated regional medicine providers in the nation. And then I have rural parts of my district. I'm from the rural part, Selma, Alabama. People know it because of the civil rights movement, but it's a small town of 19,000. And frankly, there are a whole bunch of rural communities around it that depend upon the health care that's provided in Selma to help provide for them. So my question really goes back to a question that was raised by Representative Kine. The reality is that, if we do not have any plan. This administration doesn't have any plans to repeal and replace the Affordable Care Act, but only to work towards efforts that undermine the ACA. How are rural providers, especially, going to survive? You know, I have 14 counties, and the majority of my counties, the rural hospitals actually have upwards of 90% of its patients depend upon Medicare or Medicaid or TRICARE or some federal assistance. And several of the hospitals in my district, you know, have, like I said, 90% of the patients dependent upon federal, government medical assistance. Our rural hospitals are especially vulnerable to the sabotage that we're seeing, especially when you think about the fact that we're no longer paying for cost-sharing subsidies, and the only way that so many of my constituents can actually afford health care insurance at all is through this assistance. And so I really want to understand first whether or not this administration has a plan to replace it, or are we going to continue to see sabotage efforts that only sabotage some of the benefits of the ACA, and I'd love to know your thoughts from that. You weren't able to answer, Mr. Kine.
So the ACA is the law, and we in the executive branch, it's our duty to execute the law, faithfully execute the law as it stands. So the ACA is the law of the land. We are working to faithfully execute that law.
Yeah, but are you saying that the funding stream, the fact that this administration has cut the subsidies, which actually provide the financial assistance for people to actually be able to afford health care insurance, yes, it's the law of the land, but are you denying that this administration has cut the budget for the subsidies?
Which subsidies are you referring to?
I'm talking about the cost reduction subsidies, cost-sharing reductions.
Okay, in those cases, we have had, I mean, obviously, as you may know, there were court cases involved in the decisions as well that are in the background of that where...
I'm running out of time, sir, and they have been cut. I have to also say that the cuts and slashes to the navigators also undermines the ability of constituents that I have that do want to get health care insurance from actually being able to understand what's out there and what's available in the marketplace. I have one constituent by the name of Hank who literally, when I asked him about the Affordable Care Act, was very interested in getting health care insurance, but when he heard it was Obamacare, wasn't. Thank God he had a navigator who helped him get health care insurance, because 6 months after not ever having health care insurance, he was a farmer on a rural part of my district and had never had health care insurance, and his hand got caught in one of those grinders, and thank God he had health care insurance, because he not only didn't lose his hand, but he also didn't lose his farm. So I guess I just really want to reiterate at this hearing, because we haven't had an opportunity to have a hearing about the sabotage on ACA, that the Affordable Care Act is the law of the land, and we should be doing everything we can to encourage Americans who need health care insurance to actually get health care insurance. Thank you.
Just for the record, you know, the administration's responding to litigation. So CSRs and risk adjustments are the result of litigation. So I take the Secretary at face value in terms of enforcing the law, and with that, I recognize the gentlelady from Kansas.
Thank you, Mr. Chairman. Thank you, Mr. Secretary, for joining us. Today we're here to discuss the Stark Law and possible solutions for updating the physician self-referral law to continue moving the Medicare program toward being a system that promotes better coordinated care. Stark Law was intended to reduce fraud, waste, and abuse related to physician referrals in all healthcare settings. However, the law is outdated and needs to be modernized. By looking into updating the statute, we've got the opportunity to discuss the way care is delivered today and how we can better serve Americans. This modernization will ensure that we are creating easier access to care for people across the country while also rewarding value within our healthcare system. For rural districts like mine and Mr. Smith's, I represent eastern Kansas. The Stark Law does present a disproportionately heavy regulatory burden for our hospitals, as you have acknowledged. These rural hospitals have limited patient volume that at times may necessitate the need to share specialists with non-affiliated hospitals. Additionally, there are fewer employees in rural areas, which increases the probability that a physician or a family member may work with an employer that triggers Stark implications. In both of these examples, the risk of potential financial relationships that have Stark law implications is high, generating significant additional legal effort needed to document and ensure compliance with the mandate. Mr. Secretary, removing unnecessary government obstacles to care coordination is a key priority for the administration, and you've even stated in your comments we need to change the healthcare system so that it puts value and results at the forefront of care, and coordinated care plays a vital role in this transformation. HHS is responsible for removing regulatory barriers to help providers deliver the best team-based care. Do you think these are all changes you can make administratively, or do you believe Congress may ultimately need to intervene in order for physicians to deliver value-based care?
Thank you. We are going to do what we can from an administrative point of view based on the stakeholder feedback that we get. So we're currently, through the RFI process, going to get as much feedback as we can from the stakeholder community on where we can go, where they think they have good ideas, and where they think we should go in terms of that. We're going to reflect on that with our experts at HHS and then come out with an administrative proposal to address the regulatory side that we can affect within the strictures of the law. I think when we go where we can go and where we think is going to be a positive place from the point of view both of the reflections we have from the community as well as our own, I think we'd be happy to work with you all, provide what assistance we can in where it seems likely that there could be legislative changes that would be positive here that would sort of preserve the core good part of the law, the part that's kind of animating the issue that it was originally intended to fix, which is that where we have undue issues where providers are incentivized to kind of enrich themselves in a inappropriate way, and to maintain that focus on value, because obviously we're moving to a system of value-based care, and that's what we're trying to do. And so it means that we need to keep our eye on all the elements, including the heart of the Stark Law and what it's intended to achieve. So we look forward to working with you all as you make plans, if that's where you're going in terms of modernizing it from a statutory point of view.
All right, we'll look forward to working with you. Thank you, Mr. Chairman. I yield back.
Ms. Chu.
Deputy Secretary Hargan, this is a rare opportunity for me to ask a question directly of an HHS Deputy Secretary. So I wanted to ask a question on a different issue that is on my mind, which is the health care of children and parents separated at the border. I want to read you a letter from Henry, a constituent who wrote the letter I have here in my hands. He wrote to me in pink marker and asked me to please reunite the children with their families. I take letters from my constituents very seriously, and that's why I'm going to ask you a few questions today that might get us closer to finding answers. This weekend, there were a number of disheartening reports of children who were separated from their parents at the border and have been recently reunited with them. According to a story from the Washington Post, a 10-year-old said she did not wish to remember her time spent in detention and recounted watching out-of-control kindergartner get injected with something after he misbehaved in class. Sandy Gonzalez, a second grader from Guatemala whose mother fled the country to get away from her abusive husband, was reunited with her mother after 2 months in detention, but told the newspaper that they told us to behave or we would be there forever. She cries when other children try to hug her because they always kept the boys and girls separate, and they punished us if we tried to be near each other. Another young boy named Diego, a 9-year-old from Brazil, reported falling on a concrete court while playing and hearing his arm crunch. No doctors or medical professionals attended to him, and he was given a temporary cast by the shelter's employees. Next, I'd like to enter the following article into the record. Pregnant women say they miscarried in immigration detention and didn't get the care they needed.
Without objection, so ordered.
It was published by BuzzFeed on July 9, 2018. The article describes a number of disturbing practices, including pregnant women being detained well into their 3rd trimester, being shackled across their belly, and even going through a miscarriage without being given any medical attention. One of the women in this story is quoted as saying that when she arrived to alert authorities, she believed she was losing her baby. She says, an official arrived and they said it was not a hospital and they weren't doctors, they wouldn't look after me. While the woman quoted in the BuzzFeed story was in adult detention, I'm concerned about the condition of pregnant young women who are under the age of 18 and are therefore in custody of the Office of Refugee Resettlement. Deputy Secretary Hargan, how many pregnant young women are currently under ORR's custody?
We can get back to you with that exact number,
I
Congresswoman.
would definitely appreciate that. It is my understanding, based on a deposition taken by the ACLU, that ORR Director Lloyd receives a spreadsheet each week of the number of pregnant young women in ORR custody and the gestational ages of their fetuses. If this is correct, I imagine it would be easy for you to determine the number of pregnant women in ORR custody. Last month, I joined my colleagues, Congressmembers Dingell and Custer, as well as 60 other signatories, in asking the Department of Health and Human Services how many pregnant young women were in ORR's custody and what ORR is doing to ensure that these young women are receiving adequate medical care. We have not yet received a reply to this letter, so I would like to ask you, what is ORR doing to ensure that pregnant teenagers in ORR's custody are receiving adequate prenatal care? Have any young women given birth in ORR custody? What is being done to ensure that they and their child receive adequate medical care?
So the mission of HHS and the ORR is the safety and health of the children that are given into our care. And so that is the primary focus of that, whether or not they are young women who are pregnant, the children, and any of the other children that are in our care. And that is the utmost importance for the program, and that's what we intend to carry out.
Generally, his time has expired. Mr. Secretary, if you could respond in writing appropriately when it's and promptly.
Absolutely, Chairman.
Mr. Marchant.
Thank you, Mr. Chairman. Earlier this year, our committee, with Mr. Kind's assistance, passed a stark simplification legislation. I, for one, believe that the Stark laws need to stay in effect for the private practices and the whole kickback scheme. I don't think anybody on our side believes that we should go back and remove all that. But for my constituents that don't know what value-based treatment is, could you just describe a typical procedure or a typical situation that a patient would find themselves in where our current Stark laws, the way they're written, would either prohibit them from getting the right care or would prolong their care or would make their care much more expensive?
Sure. So an example of sort of uncoordinated care, right? So right now the Stark law can prohibit different groups of doctors and other types of providers from affiliating with each other, from having relationships with each other. They make it much more difficult. So when you have a situation where you have, say, a primary care doctor who is often the first person that a patient sees is their primary care doctor.
Yeah, I think everybody on this panel understands that, but if you're talking to somebody back in my district and you're going to talk to them about a specific, say a knee surgery.
Sure. So say a knee surgery, you got an orthopedic surgeon who's going to be involved in the knee surgery. They might have a lab that they order lab tests from, a pain center that they refer them to, a rehab center where the patient would go for rehab with physical therapy, primary care doc who is the original person involved in this, a hospital that could be doing something, could have a role to play on the side. Any number of organizations that could be involved in this. Right now, the Stark law can prohibit a lot of the relationships that can develop among those different kinds of providers.
And when you say value-based, you mean pretty much we're going to pay you this much money from the first visit to the last visit.
Right. So that's certainly a common way of looking at value-based care. Value-based care means really paying for outcomes and for the value in the procedure. And many times that is seen as a bundled system, or you can call it any number of things, but a bundle or a single payment that you were mentioning, those are examples of value-based care.
And so an insurance carrier could look at that and say, here's our maximum exposure on that procedure, and theoretically back into either a lower premium ultimately or keep costs from escalating.
Yeah. Any payer could do that, could say, I'm going to pay a single bundled payment for an episode of care. That's a common way of looking at it.
But under our current law, the way the Stark laws are written, a lot of that can't happen simply because to achieve that bundle number, you've got to have some affiliation and some association.
That's certainly an easy way to do it. There are certain types of entities that can coordinate that care right now. A hospital could have everything in-house, but it's not necessarily the case that a general hospital is always going to be there, able to perform from A to Z a particular episode of care, and you may want to create affiliations between groups of providers that aren't necessarily owned together, or they're not necessarily affiliated in a certain way, to be able to create those relationships among one another. Stark law is often seen as acting as a barrier.
Thank you. Thank you very much.
Mr. Paulson.
Thank you, Mr. Chairman and Deputy Secretary Hargan. I want to thank, first of all, CMS for issuing recently the Stark Law RFI that came out actually just a few weeks ago to get public input on ways that we can more responsibly modernize Stark and then promote that shift towards value-based care. But now the Stark Law isn't the only law that's designed under fee-for-service that's been an obstacle in this shift to value-based care. You've got the anti-kickback statute as well, which is also meant to protect against fraud and abuse by limiting certain types of financial arrangements. But equally, I would say we're probably losing opportunities for better support for coordinated care, for innovative care delivery, for new payment models for the benefit of different providers and patients. And now under this value-based payment arrangement, or the opportunity for it, you're going to have goals of the parties and of the providers and the payers and the medical technology manufacturers, others, et cetera, that can all use their data, all the information they've collected to help better financially align, incentivize each other, right, to coordinate care and improve outcomes. Would you agree that it's responsible also to analyze or look at the anti-kickback statute as well?
Yes, absolutely. And so I have sponsored what I call the regulatory sprint to coordinated care within HHS. So I brought together CMS, the Inspector General's Office, the Office of Civil Rights, which oversees HIPAA, and SAMHSA, which in the opioids area oversees 42 CFR Part 2, which is another rule that has been seen by stakeholders as blocking some kinds of coordinated care, particularly with regard to substance use disorder and opioid issues. That's obviously a vital interest of this administration and the president. So we brought together actually 4 different agencies to be able to coordinate amongst themselves so that they can align with each other to create a system of coordinated care so they don't act against each other, and that we end up with kind of a reform that we can do in respecting the law and respecting the goals of the laws, but that we believe we can reduce some of the duplication, the overlap, and the contradictions among the different regulations that our agencies have come up with on their own. So the first part was Stark, because when I launched this regulatory sprint, the staff at CMS were ready to go. They had seen a lot of the issues that had arisen on their watch over time and were ready to go. But the Inspector General is also on board with this, as are our other agencies, in order to achieve this coordination. So the anti-kickback is absolutely being looked at in this area. Obviously, the Inspector General is going to enforce the anti-kickback statute, but they are fully in line with the idea of value-based care and with the notion that they need to be talking to one another. The agencies of HHS need to talk to one another and make sure that they're not sort of strangling innovation and new models of care that are going to be for the benefit of the American people.
Would there be a similar situation where you do an RFI on anti-kickback, for instance, for that input?
Yes, exactly. So that's what I'm asking the agencies to do.
Okay. Thanks, Mr. Chairman. I yield back.
Mr. Reed.
Well, thank you, Mr. Chairman, and thank you, Mr. Secretary, for being here today. I kind of want to follow up kind of what my colleague from Texas, Mr. Marchant, was kind of getting to. And I always try to ask these questions from the perspective of a constituent, from an actual patient perspective. So I'm a patient who is in Medicare. Not that old yet, but the hair gives it away. The question I have for you, with the Stark laws on the books today, and as we go to a capitated, value-based type of reimbursement model, what kind of care do I potentially not have access to? What would be my experience under that if the Stark rules are not modernized like I believe they need to be done?
Sure. Well, you know, put yourself in the perspective of a patient. We're all patients of the American healthcare system. We're all patients and potential patients of the system. So I think, you know, we're all, you know, I have a perspective of a patient. Everyone here does, potentially. So we're always going to try to maintain a focus on the patients as the center of care for the system. What can't you get right now? You can't, you might have to, in circumstances, be responsible for knowing every single element of the chain in medicine. When you are diagnosed with something, the doctor that diagnoses you might not know the right specialist. They might not know the right provider. When you go to that specialist might not know the right lab. They might not know the right other providers that are needed. The physical therapists, I'll just take the orthopedic, go back to the orthopedic thing. They might not know the physical therapist. You might have to find in a moment of sickness, in a moment when you're trying to get care, when you're under pressure, you're going to have to know all that yourself.
As a patient, from a patient perspective.
From a patient perspective,
that's the scenario we're looking at if we do nothing.
You've got
where a patient would be have the obligation and responsibility potentially to know exactly who's going to run afoul of this Stark law, who's going to run afoul of these proceedings.
In other words, the providers in many ways are not incentivized to talk to each other. They are not incentivized to coordinate. They can't coordinate in many cases because this is going to cause a big problem for them legally.
Because of the Stark law, because of the way it exists today.
Exactly. And so you, in many cases, are on your own. It's much harder to coordinate in the system that we have now. Now, there's a lot of information out there, and people do get along. And there are systems, you know, big provider systems that are all owned by the same owner, and they coordinate, and there are exceptions here and there. But what we've done is we've created 40-plus exceptions to the Stark law to address this. It is a Swiss cheese in many ways, and there is, at this point, we're decades down the road in interpreting the Stark law, and that's why we're trying to kind of look at a revamp to be able to reform this law from a regulatory point of view to create a better way for patients to be able to get coordination. So
that way, when I'm a patient walking into a physician's office or a provider's office, I don't have to take on that responsibility to know where I have to get my cancer treatment, my rehab, my counseling, mental health counseling, and all that, because now, under the new model, with a modernized Stark law, that could be driven from the patient's advocate, the patient's provider, who then would be able to have seamless care from my perspective as a patient. Is that yes, what we're trying to achieve?
The idea is to be able to have more seamless care within the system and better coordinated care overall.
And I truly appreciate that. And I think from the perspective of a patient, that should be the joint goal we achieve through this process. Thank you.
Mr. Kelly.
Thank you, Chairman. Secretary Hargan, thanks so much for being here today. You know, the chairman has been, over the past year or so, working on a Medicare red tape relief initiative. And over the past few months, we have brought in dozens and dozens of doctors and providers to discuss ways we can make the system better. Your department is also undertaking a similar project, appropriately named Patients Over Paperwork Initiative. And some of the main points we hear again and again is how outdated government regulation gets in the way of innovation in the doctor-patient relationship. This feedback also included how Stark law is adding to the growing administrative burdens. I can just tell you, from being in the private sector my whole life, being in compliance requires so much non-productive labor. in order to get up to speed with this, and they're constantly checking and rechecking and making sure you're in the right position. And it's, I think the same thing's happened with the healthcare system. It's incredibly difficult to keep up with all the compliance issues. Now, I think the idea behind all this is how are we going to make it easier and not harder for doctors to take care of their patients? And I'm just, if you can, just share a few ideas of HHS, of how you could streamline this process, get rid of all the red tape that really, I don't know at the end of the day if people could say, yeah, this was really great that we did this and we're making sure all this is taking place, but does it actually add value to the American people's healthcare system? Right? So some of the ways you can streamline it and taking a look at it from a private sector initiative of how you would handle that as opposed to how government does it.
Sure. So to go back to the Patients Over Paperwork initiative, that's obviously an attempt to kind of, again, elevate that over the huge amount of regulatory red tape that has been allowed to kind of encrust the healthcare system over time. This is an attempt, we're broadly attempting to reform our regulations and the processes that we have in place in order to liberate those resources in terms of time and in terms of money so that we can dedicate more resources to patient care. You know, there always does have to be accountability. Obviously, Medicare and Medicaid are funded by the taxpayers, and so we have to focus on that to make sure that, again, it's value-based care, right? We want to make sure that the money that is being put in through these programs is being, we're making sure that our stewardship of that money that's been entrusted to these programs is being spent on patient care. In many cases, many well-meaning attempts to provide oversight and to be able to see exactly what's going on in the system has resulted in overlap, duplication, the proliferation of measures that have not advanced patient care or good stewardship of the taxpayer dollars, but have instead resulted in kind of a negative effect on all of that. So we're attempting to do that. I think that's what CMS is trying to do with many of the initiatives that are going on there. One of the initiatives that there's a lot packed into the new Medicare rules that are coming forward, so we're sort of continuously trying to reform this system.
Yeah, well, I just think, if we could model the government the way the private sector works, where you have to become more effective and efficient, that way you get a better result. And what we're looking here for is outcomes for the American people. I thank you for the work you're doing, and it is a large challenge, and we have to get some kind of a sense of control over it. But thank you very much. I yield back, Chairman.
Mr. Blumenauer.
Thank you, Mr. Chairman. I apologize for the delay. I was defending the honor of the Ways and Means Committee before rules on HCON Res 119 about condemning a carbon tax. And I want you to know that you can rest easy tonight, that the resolution doesn't mean anything. It doesn't relate to any specific carbon tax proposal. There's not been a single hearing on a carbon tax in our committee or any place else, and so you don't have to have your people do a real deep dive on this sense of Congress resolution. And in fact, it's going to be a nothing burger, but I made the case for the committee for you on your behalf.
Hear, hear.
Mr. Chairman, I would, with your permission, request that we enter into record a statement. This is the 398th hearing that we have had since Republicans took control of the Ways and Means Committee. And in that time, we have had one 5-minute witness testify about meeting our responsibilities for infrastructure finance. And as the Health Subcommittee, I would just say this makes a difference for the health of Americans. In 2016 alone, 37,461 Americans were killed in fatal automobile crashes, 1 every 14 minutes. More than 2 million Americans are routinely injured in traffic accidents. The health impact of long commute, traffic congestion, it's rather substantial. It has a significant impact on the health and well-being of our communities and our citizens. And our failure to meet our responsibility to help fulfill opportunities to deal with an infrastructure crisis, I think impacts our health, and I hope that at some point in the near future we'll be able to address that.
Is there a statement for the record? Is there something
I
you want to?
actually have a statement for the record, Mr. Chairman.
Without objection, so
which
ordered.
I would like to enter in.
So
Thank
ordered.
you. You're very kind. Mr. Chairman, I would like to identify myself with the concerns that were indicated by my friend and colleague from California, Ms. Chu. These are issues dealing with the treatment of these children. We hear really rather grotesque stories. I hope that most of them are not true or that they might be exaggerated, but they're frequent enough from a variety enough sources that gives us all pause. And so we really would appreciate being able to dig in and provide some information. I have just one question to you. I am unable, nor were two senators from my state and other members of Congress, able to be able to visit one of these centers, which is 5 blocks from my office. That instead of being able, as we do routinely in terms of oversight and inspection, to be able to show up and look at true conditions. There's sort of this elaborate process we have to go through other committees. Is there some reason why members of Congress are unable to be able to visit these facilities, to be able to understand the conditions and satisfy for ourselves in a timely and orderly fashion?
Sir, members of Congress are absolutely allowed to visit these facilities. In fact, we have already organized tours that over 70 of your fellow members of Congress have have come to ORR shelters and have been able to inspect them.
These are orchestrated in advance. We don't have an opportunity to show up and actually look to see how they are not being staged for a tour.
The gentleman's time has expired.
Oh,
could I suggest that you respond to Mr. Blumenauer's inquiry?
Yes.
Thank you.
Thank you, Mr.
Dr.
Chairman.
Wenstrup.
Thank you, Mr. Chairman. Thanks for the opportunity today to be with everyone. You know, it seems to me as a doctor, when Stark laws came about, it was idea that there are some people that are acting out of greed and that we should probably do something about it. But from my standpoint, what it ended up doing is where you have some bad actors, we made everyone stay after school and have to be subject to a lot of things that made it more and more difficult to take care of patients. And one of the things you talked about today was coordinated care, and I agree with that. How can you coordinate care more expeditiously and in a better manner for patients? But the laws made it very difficult and challenging and nerve-wracking. In our group of orthopedic surgeons, we had one doctor who was an orthopedic oncologist. He was really the only one in town. And so if I had a patient that I saw that had a bone tumor, that's who I want them to see. But since he was in my group, we had to be concerned, can I actually refer to him? Because that's part of my group, and it's like a self-referral. And we worried about that. And of course, we got waivers, and oh no, that can be okay. But then we went through it with physical therapy. So you have your own physical therapy, which is great because it's right down the hall. You can keep track of the patient's progress. But we're operating under the assumption that you only referred them to physical therapy, not because they needed it, because it's some revenue for you. And so we had to get rid of our physical therapy because we were worried about Stark laws and sell it off. And then we realized, well, you can have your physical therapy, and then we bring it back. This is years later. This does not make patient care better, and that's really what it's about. And I just want to say, as a doctor, I sit here when most doctors, large majority of doctors, are worried about quality and outcomes for their patients as well as being efficient and affordable. That's really what we're trying to do. And then you have all these laws that sort of assume you've done something wrong. And so as we're talking about this, and I think you're probably on the same page with us, how do we modernize this, that we are able to see who bad actors are and address that situation, at the same time, let doctors take care of patients and let patients be taken care of in a smooth, coordinated way?
Thank you. Yes, I mean, I think that we share those same goals, and we hear a lot. We have been hearing already a lot from the stakeholders that we've reached out to with the RFI. It's identified as one of the top, if not the top, issue on which we have heard feedback from stakeholder community, particularly from providers, physicians, that this is one of the main areas that they urgently seek reform from us for the reasons that you articulated, similar reasons where the patient is not getting the smooth coordination of care, and that in many ways the law, which again, well-intentioned, and there's a core element of it that I think everyone knows is necessary, but that over time there has been interpretation of the law and regulations that have perhaps produced results that aren't optimal for the patients and for their care.
And as an aside to that, if a patient said, look, you know, I drive 50 miles to see you, but physical therapy twice a week or 3 times a week is too hard, can I see someone near me? Absolutely, we'll work with it, whatever's going to be best for the patient. That's really where we want to go. Thank you, I yield back.
Thank you. Well, Mr. Deputy Secretary, thank you for your insight this afternoon. I think we've all benefited from it. It's interesting, too, you can listen to sort of the subtext of the discussion, and the subtext of this discussion was a lot of common ground on Stark, a lot of recognition that what we have is a legacy that has, it in its current form is not serving us, it's not keeping us safe from things that threaten us anymore, and now it has become actually an obstacle. And so the big question is, how do we move forward and modernize this? How do we update this? And many times, this is just sort of the nature of legislation and regulation. Regulation and legislation tends to lag. It's sort of the nature of the system. Now we've recognized that with this transition, we've got to update this. And, you know, notwithstanding some of the, you know, partisan sort of comments here and there, and that comes with the territory, I think there is a real desire on the part of this subcommittee to try and modernize and update this. So without objection, I submit an article that was written this afternoon by kind of an odd couple of healthcare politics, and that is former Secretary Tommy Thompson and Kathleen Sebelius, regarding the importance of moving away from traditional fee-for-service and modernizing laws like Stark to achieve higher value. So close us out. Stretch your legs a little. What would you want us to be mindful of as we transition and basically begin to think about what this could be like? What do you want us to know about?
Yes. Well, I think that just to reiterate what we've been talking about altogether, to sum up, I think that it's great to see that you and this subcommittee have recognized broadly that this is a real problem for us as we try to make, as a nation, the transition from the fee-for-service system to a system of value-based care that I think is going to result in higher quality, can result in higher quality and lower cost for the American people, and a lot less stress and anxiety for them as they are able to have better care coordination and be able to be taken care of from the beginning to the end of their interactions with the system. So, you know, I look forward both to working with you, to keeping you all apprised of what we're doing in terms of trying to undertake regulatory modernization to the extent that we can, respecting the law as it stands today, and then providing you with whatever information we have, both from our outreach to the stakeholders, to the provider community, and then the results of the reforms that we're making to help inform you as you all move forward with perhaps modernization efforts of your own that you that you undertake here from a statutory or legislative point of view.
Very good. Well, Secretary Hargan, on behalf of the subcommittee, thank you for your time. And if you could respond to the members who had other questions, you can respond to them directly. At this point, we will dismiss you and thank you, and we'll welcome the second panel to assemble at the witness table.
Thank you.
Okay, while people are gathering, I'm going to take advantage of the time. We've agreed to move witness or member questions to 3 minutes, so let's move some traffic. What do you say? I'm going to recognize Mr. Wenstrup for the purpose of introducing one of our witnesses.
Thank you, Mr. Chairman. I'm pleased to recognize and introduce Dr. Gary Kirsch, who is a longtime friend and colleague from the Cincinnati area where we practiced in the same circles for many years. He is from a 35 urologist group in Cincinnati, Ohio. It's an independent urology company serving all regions of the Cincinnati metropolitan area, and I can tell you they do a great job. And they've really tried to coordinate care for patients where they operate and own their own surgical, imaging, laboratory, radiation, and clinical research services, which has been a large asset to our community. He's been instrumental in founding the large urology group practice association and has been involved with legislation and health policy for many years, and we appreciate that. And he is a graduate, got his medical degree in Chicago, did his residency in Cleveland, and we're glad that he chose Cincinnati to practice. And thank you, and I yield back.
To round out the rest of our witnesses, we have Mike Lappin from Chicagoland. He's the Chief Integration Officer at Aurora Advocate Health. Brian DeBusk, President and CEO of DeRoyal. And Claire Sylvia, Attorney at Law at Phillips & Cohen. You each have 5 minutes. Dr. Kirsch, you're recognized.
There you go, sorry. Thank you, Mr. Chairman and Ranking Member Levin, and thank you, Congressman Wenstrup, for the generous introduction, and it's great to see you here again. I am a practicing physician, a urologist. I'm president of the urology group in Cincinnati, as the Congressman mentioned. I also represent an organization called the Large Urology Group Practice Association, known as LUGPA, and we represent the independent, freestanding urology group practices in the country, collectively providing about 35% of the nation's urology services. Our commitment to value-based care predates the ACA and MACRA, and LUGPA heartily embraces the Congress's vision of value-based care. Unfortunately, it's my duty to tell you and to report to you today that the vision of MACRA and value-based delivery is in serious jeopardy. According to CMS, currently only 5% of U.S. physicians are even participating in alternative payment model arrangements. More troubling, there are almost no APMs in the pipeline. In the 2.5 years that PTAC has been operational, only 26 APMs have been submitted for review. Of these, only 4 have been recommended for implementation and 6 for limited scale testing. Moreover, not a single PTAC-recommended APM has been enacted by CMS. Last month, PTAC had a regularly scheduled meeting for hearing APM proposals from the medical community. The meeting was canceled due to a lack of submitted proposals. The Stark and associated fraud and abuse laws are one of the principal barriers to the development of alternative payment models. The Stark law was written nearly 30 years ago, as you know, and has not been substantially modified since 1993. Congress recognized long ago that the Stark Law was an obstacle to care coordination and value-based delivery when it authorized the Secretary of HHS to waive the self-referral and anti-kickback prohibitions for accountable care organizations. Yet, independent physician practices were left behind. Congress needs to, in our judgment, level the playing field to provide the same protections for independent physicians to test and participate in APMs that were offered to ACOs. While HHS can grant waivers to approved APMs, it's important to understand that organizations and practices wishing to engage in APM development find themselves in a catch-22. We cannot test an APM in the real world without financial waivers to Stark and anti-kickback laws, yet these waivers cannot be granted unless there is an approved APM. Organizations such as ours, frankly, may spend years of work and substantial investments designing an APM, but it remains a theoretical, mathematical model whose actual impact on patient care and healthcare financing is unknown without testing in the clinical environment. Moreover, case-by-case waivers granted by HHS are also typically narrow and cannot foresee real-world circumstances, such as evolving standards of care or new innovations or other circumstances that affect physician behavior and require modification of waivers. Stark Law additionally represents a barrier to APM adoption in that it prohibits compensation to physicians who receive revenue from designated health services based on the, quote, volume or value of their referrals to these services. While this makes sense in a fee-for-service model, and we do not dispute that, it is not relevant in alternative payment models under which practices accept risk and financial exposure to Medicare is limited. The volume or value prohibition prevents practices from utilizing revenue from designated health services to financially reward or penalize physicians for adherence or deviation from clinical best practice standards. Our ability to financially incentivize physicians for clinical pathway adherence is crucial to success in a value-based construct. Eliminating volume or value from Stark prohibitions for the testing and operation of APMs would result in a clean, targeted, modernized version of the Stark and anti-kickback statutes. We must be able to pay for value, frankly, in a value-based arrangement. To be unable to pay for value in a value-based arrangement is sort of a non-starter, frankly. These are the reasons why LUGPA and 24 other diverse physician organizations have endorsed the Medicare Care Coordination Improvement Act, H.R. 4206, which eliminates the volume or value prohibition in APMs and also provides a means for HHS to grant waivers to test a proposed APM when it is submitted in writing and approved by the Secretary. Importantly, these waivers are not indefinite. They must be recertified on a semi-annual basis until the APM is approved or denied. We fully recognize there is no panacea that would transform healthcare delivery into a value-based system overnight. We do not advocate modification of the Stark Law as it relates to Medicare fee-for-service. That said, Stark Law must be modernized to allow for the creation of alternative payment models. These models represent innovative delivery systems that will increase care coordination, improve outcomes, and decrease cost. I thank you for your attention and would be happy to answer questions, Mr. Chairman.
Thank you. Mr. Lappin.
Thank you. Mr. Chairman, Ranking Member Levin, and members of this distinguished subcommittee, thank you for convening this important hearing and allowing me the opportunity to share some of the more significant barriers we have faced under the Stark Law and other laws as we have moved towards a value-based care delivery model. I will also suggest some solutions that Advocate Aurora Health urges Congress to consider. I am the Chief Integration Officer of Advocate Aurora, the 10th largest not-for-profit integrated health system in the United States. We serve nearly 3 million patients annually in Illinois and Wisconsin across more than 500 sites of care. Our system is committed to the delivery of value-based care and participating in innovative reimbursement models intended to improve outcomes and better control costs. Roughly 50% of our patients are in some type of value-based payment model. We also operate one of the largest ACOs in the country and have achieved millions in cost savings for taxpayers while remaining among the highest in national quality results. Dr. Lee Sachs, our Chief Medical Officer, testified at a roundtable of hospital providers held by this subcommittee in April on value-based care, during which he mentioned the need for stark modernization. I welcome the opportunity to continue this important discussion with the subcommittee today. While our system has been successful in driving care delivery improvements and cost savings through the provision of value-based care, the Stark and fraud and abuse laws in their current form are stymieing our efforts and our ability to drive future success. Here are a few examples. Gain sharing. We only pursued a test of a gain sharing system in which we would align some physician compensation to outcomes by sharing a portion of the savings generated through new care models and standardization with physicians on a much more limited basis than desired, although it met OIG guidance, because we are not comfortable with the risk posed by not having a clear Stark exception. Data analytics. We would like to share our analytics platform being developed and other innovative technologies with physicians that are closely aligned with our system, as we did with our EHR. But there is no exception to Stark for the analytics tool or other technologies like there is for our EHR. This data analytics platform will guide clinical decision-making in a value-based environment. We've already experienced several successes, including dramatically reducing the number of high-risk heart failure patients presenting for admission in our hospitals and emergency rooms. Innovation. Ironically, in many situations, it is riskier for us to work with a physician, a new business venture started by a physician who cares for our patients our greatest source of innovation, rather than a physician who does not, because making it an investment in or providing other support to a venture started by one of our physicians implicates Stark. Here are 3 solutions we propose to help modernize the existing Stark law. Provide exemptions for participation in value-based arrangements. Properly structured APMs typically have built-in safeguards, such as careful monitoring by CMS and a payment system that rewards value and inherently protects against inappropriate self-referral and overutilization. Existing waivers only provide limited protections. Make Stark intent-based. Make penalties proportionate to the violation. A major problem with the Stark law is that it is a strict liability statute. Penalties are disproportionate to the violation, and intent to violate the law is not considered. And all noncompliance, however minor or innocent, constitutes a violation of the law, potentially resulting in severe penalties. And reduce confusion in the application of Stark and the intersection of other laws. Clarify the requirements for key terms used in Stark, such as fair market value, which have been interpreted by courts differently. And seek to reduce overlap between Stark and other laws, which creates confusion and burdens us with our efforts to comply and manage the care of our patients. We urge Congress to provide HHS and OIG with greater rulemaking authority to align the Stark law exceptions and other laws requirements to create a cohesive regulatory regime that can protect patients while still allowing for innovative care arrangements. While we have achieved significant success to date, we feel strongly that there are additional opportunities to unlock the full potential of innovative APMs for improving care quality and reducing costs for patients, taxpayers, and the nation. If we had a clear exception authority or assurance that certain high-quality initiatives would not run afoul of existing Stark requirements, we believe we could take on more risk and move more quickly to implement a truly value-based healthcare system. The Stark law needs to be modernized to meet patient needs and expectations. Thank you again for this opportunity to testify on the Stark law and recommended reforms. I'm happy to answer questions that the subcommittee has on this topic.
Thank you, Mr. DeBusk.
Chairman Roscom, Ranking Member Levin, and members of the subcommittee, thank you for the opportunity to testify. My name is Brian DeBusk, and I'm the President and CEO of DeRoyal, a medical device manufacturer with approximately 2,000 employees worldwide. I appreciate the opportunity to speak with you today about ways to improve the delivery of health care through better physician-provider alignment. Medicare Stark law plays a critical role in ensuring adequate financial separation between doctors and providers to whom they commonly refer patients. Induced utilization created by potential conflicting interests places beneficiaries and taxpayers in harm's way. Therefore, I would like to emphasize the need for caution when considering ways to make significant changes to amend the Stark law in an unfettered fee-for-service environment. Yet today, physicians and providers are being encouraged to align their activities to be more patient-centric, improve care coordination, and facilitate delivery system change. And to support this transformation, the Stark law should be modernized. Waiving certain elements of the Stark law is not without precedent. Even in its earliest form, the Stark law exempted what we now refer to as the Medicare Advantage program from many of its provisions. Policymakers recognize that in a capitated, risk-borne environment, checks and balances exist to curtail the risk of induced utilization the Stark law set out to prevent. Similarly, when providers share risk in a fee-for-service environment, there's diminished upside to increasing utilization through referral as it diminishes potential shared savings. To that end, Congress has further encouraged care coordination by giving Medicare providers new tools for managing cost and quality through programs like the Medicare Shared Savings Programs, demonstrations managed by the Innovation Center, and MACRA's payment incentives. Many, but not necessarily all, of these alternative payment models incorporate some form of downside risk. While the financial constraints aren't as direct as the risk-borne capitation found in Medicare Advantage, they do represent a significant waypoint between unmanaged fee-for-service and private plans. Many of the APMs already include Stark law waivers. However, it appears these waivers are not used to their fullest. Why? One is an issue of past practice. For the last few decades, the Stark Law has cast a long shadow over physician-provider financial arrangements and, as intended, has served as a strong deterrent. Of the current initiatives, in my view, accountable care organizations, ACOs, represent the most promising platform for moving Medicare toward a managed fee-for-service model. ACOs already have generous waivers that exempt them from major portions of the Stark Law. For example, the next generation ACO model waives most of Stark's financial arrangement provisions. Again, it appears these waivers are not used to their fullest. I believe the reason is twofold. First, because the waivers are issued on a case-by-case basis, there's an inherent uncertainty as to their evolution over time. Codifying these waivers into law would give physicians and other providers the certainty they need to invest in and support the transition to value-based care. Second, we need to strengthen ACOs themselves, particularly models that incorporate downside risk. ACOs serve as the substrate for the transition to value-based care, which is the underlying driver for these hearings on Stark modernization today. I commend policymakers for the improvements made in terms of beneficiary attribution and spending benchmarks within the ACO programs, but more needs to be done to provide certainty and encourage physicians to become active participants in these models. It is safe to say that the issues of Stark modernization, the proliferation of successful ACOs with downside risk, and the successful implementation of MACRA are all inextricably linked. In summary, there's an exciting opportunity to modernize the Stark Law so as to support the transition from volume to value. Thank you for allowing me to testify today. I look forward to answering any questions you may have.
Thank you. Ms. Sylvia.
Thank you. Thank you, Chairman Roskin, Ranking Member Levin, and members of the subcommittee. Thank you for the opportunity to testify this afternoon. My name is Claire Sylvia, and I'm a partner in the law firm of Phillips & Cohen, which represents whistleblowers in False Claims Act cases. The False Claims Act is one of the primary ways that the government enforces the Stark and anti-kickback laws. I'm offering this testimony on behalf of Taxpayers Against Fraud Education Fund, a nonprofit organization that provides education and supports the federal and state false claims acts and laws intended to protect taxpayer funds. The president and CEO of Taxpayers Against Fraud, Bob Patton, is here with me today. I've submitted written comments for the record, and I won't repeat them here this afternoon. I want to address just three general arguments and respond to them that have been made about the need to reform Stark. This afternoon's hearing is to address ways in which the Stark self-referral law hinders the development of value-based coordinated health care and provide possible solutions to this concern. We believe really the threshold question for this subcommittee is to identify specifically what, if any, problem exists related to the development of value-based care that needs to be rectified and can't be addressed within the existing Stark framework. Stark is a critical tool for the government in checking conflicts of interest and in the delivery of federally funded health care and ensuring that patient needs, rather than financial interests, are the focus of medical decision-making. Proposals to eliminate or substantially curtail application of this important anti-fraud law to broad, undefined categories of arrangements should be approached with caution. I'll touch briefly on several arguments that have been advanced about the need to amend Stark, many of which predated the move towards value-based care. First, that the law blocks or restricts innovation. Second, that the law is too complicated. And third, that the penalties and compliance costs are too high. With respect to innovation, which sounds like something we can all support, the case hasn't been made that the law as it exists and the ways of providing for regulations and advisory opinions stands in the way of innovation. To a degree, all ethics laws restrict the ability of persons or industries to innovate, but they do that because there's some important value that we place above unrestrained innovation. Here, that value is ensuring that financial interest doesn't skew healthcare decision-making that affects patients. And this is particularly a concern where the government subsidizes those healthcare decisions on a vast scale and cannot easily evaluate each transaction to determine if it's compliant with healthcare patient needs. If there are specific arrangements that do not present a risk of conflicts of interest, there are existing mechanisms to propose them and to have stakeholders opine on how those arrangements may or may not implicate conflicts of interest. Those mechanisms may not work as quickly or as efficiently as the regulated community may want, but taking the time to evaluate competing claims is necessary to help avoid unintended consequences. We've also heard the law is complicated, but it's important to remember that the basic idea of the Stark Law is pretty simple. The regulations that expand on the exceptions to the law provide flexibility in a changing environment. As we've heard, laws can sometimes not keep up with developments in industry, but the regulations allow for flexibility to address those changing environments. The regulations allow providers to structure arrangements in ways that do not violate the broad prohibition on self-referrals. We've heard a lot this afternoon that people find it difficult to comply, but there are many circumstances where they can comply. There's no necessary indication that the law itself needs amendment. The regulatory process provides the flexibility to address changes in the healthcare field without undermining the basic premise of the statute, which has stood the test of time. The penalties for violating Stark are high, but there's a reason for that. Without high penalties, violating the law can be just the cost of doing business. The purpose of high penalties is to ensure that providers take this prohibition very seriously. What is at stake is taxpayer money that is spent on individual patients who are affected by those decisions. These are not minor issues. According to the GAO report that was issued this month, the federal government spent $700 billion in 2017 on healthcare. Requests for blanket exceptions to the fraud laws that prevent those funds from being expended inappropriately should be approached with extreme caution. I thank you, and I look forward to the opportunity to answer any questions that you may have.
Thank you all very much. I think we all learned, and I know I greatly benefited from each of you and your perspectives. I yield to Mr. Paulson.
Thank you, Mr. Chairman, and we've had a very good, healthy discussion and testimony, which we appreciate today. Let me just follow up, maybe Dr. Kirsch or Mr. DeBusk, if you can answer. So as part of the committee's Medicare Red Tape Relief Initiative, which has been ongoing, Chairman Teaberry did this before Chairman Roscom continued the effort, where we actually received dozens and dozens and dozens of comment letters from a multitude of all these healthcare providers complaining about the burdens that were associated with the Stark Law. And that includes burdens that get in the way of coordinated care, burdens that get in the way of these confusing documentation requirements, actually. And the violations that are associated with documentation requirements can then lead to these severe penalties. And I'm wondering if you can just maybe provide some examples of what are some documentation examples that could be identified where this is distracting from patient care and it's leading to violations of Stark. Some of the problems, and any of you can comment.
One example that immediately comes to mind is the documentation necessary, for example, to do fair market value estimates anytime you're trying to enter into a direct or indirect compensation arrangement with physicians. I know that providers and physicians experience a lot of angst and a lot of legal work just trying to get these basically quotes to determine fair market value.
Anyone else? Dr. Kirsch, anything to add, or Mr. Lapham?
Well, the genesis of your question is related, I think, toward the fee-for-service system that we currently are operating in. And we do operate in that system, and we do have burdens with Stark, with complying with Stark. I do agree that Stark has done its job. It's curbed fraud and abuse. Within the fee-for-service context, it does make it very difficult for us to structure relationships with other provider entities that we would want to provide care for the beneficiary. This is actually more important in an alternative payment model construct, which is the emphasis of my comments today. But even in the fee-for-service environment, if, for example, a urology group wanted to coordinate care with an oncology group in the community to provide a comprehensive suite of services to patients with prostate cancer, We have lots of barriers in doing that, and I understand testimony here regarding the severity of the penalty being important to guard against abuses, but when the penalties are so severe that you're afraid to even enter into any arrangements to care coordinate with other physicians, then you really can't get anywhere. I want to emphasize, though, that that's in the fee-for-service construct, and the focus of our argument, at least from me today, is that we really need much more reform in the alternative payment world.
Thank you. Thank you, Mr. Chairman.
Mr. Levin.
You know, as I've listened to this, I'm really saddened that the focus in this Congress has been to dismantle the Affordable Care Act. What we should have been doing is discussing issues like this. Instead, it's been this negative effort to rip up what's provided health care coverage and insurance for the first time for millions of people. And I think that's a sad commentary on what has been the focus of the majority here. We should be discussing issues like this instead of being destructive. I was on the committee during the putting together of much of the Stark Law. The focus then was something very different. We didn't have these new models. And the problem was we saw abuses where people, physicians and providers, were referring people to entities that were owned by the person who was making the referral. I don't remember discussing this issue hardly at all. So now it's changed. And I think the challenge is this: how are we going to make sure that within this new model that so many of us work for in the Affordable Care Act, value-based, that there aren't new problems and new abuses? We don't want hospitals paying physicians to refer patients to their hospitals, right? And we don't want companies that make medical devices paying physicians to use those devices. That's a somewhat different set of problems. And so, Mr. Chairman, I think what we need to do is now to shift our focus entirely and to make sure that as we move to a model, that we have a structure that alerts ourselves to new problems and new potential abuses, and not simply sweep aside a stark structure that worked fairly well, though there was endless controversy, for fee-for-service, and make sure it works as we move to a value-based system. And again, it's really sad that the focus these last years have been 50, 60 bills to destroy what's brought health care to millions of people. So I hope, Mr. Chairman, from here on in, there can be an emphasis on a constructive discussion like the four of you have presented.
Mr. Kelly.
Thank you, Chairman. Thank you all for being here. I know you leave your private lives to come here and testify in front of us and to give us some look into the way we could make the healthcare system something that's actually better for the patients and actually more affordable for taxpayers who subsidize quite a bit of this. I'm interested, though, Dr. Kirsch, when you talked about, was it alternative payments? I come from an altogether different world. I know it rankles some members when I talk about how the automobile people handle warranty work, and I got to tell you, there's so many times that we do work, we base it on three things. Number one, we establish a repair order. An owner comes in with a complaint. We try to determine the cause of the complaint, and then we come up with the correction. So we call it the 3 C's. But what you're looking at, though, aren't we looking at how do we drive and how do we look at innovation and technology today to collect data that would show you exactly where things are trending? The only thing I find wrong with the Stark piece, maybe not the only thing, but the assumption that somehow These doctors are working in collusion with their groups or with other people in order to run the costs up so they can pad their own pockets. I would just think that's awfully difficult to do, to sit there and assume that everybody's in that ballpark. And I'm not saying that's what everybody thinks, but that seems to be the way the Stark went. But alternative payments are what I'm looking at. So when you talk about that, doctor, anybody else can weigh in on this. Listen, we have a huge challenge in front of us. But my assumption is most of these people spend all their time in med school, and they go and they do their internship, and they come out because they want to help people. And I think we're making it so hard for them to make that decision. A lot of them are opting out early on and say, why in the world would you incur all that time and all that debt and come out and not be able to have a sustainable business model? So if you can talk to me about the alternative payments, I asked Dr. Wenstrup what that meant. So if you could just kind of walk me through that.
Well, I'd be happy to, Congressman. Thank you for the question. In the transition to value-based care, the concept is that we're going to create new payment models whereby the payer, in this case Medicare, is going to compensate a group of providers for achieving a certain health outcome for a certain population of patients. And in the proper payment model construct such as that, the volume of referrals to any particular service really become somewhat irrelevant. And what is needed is the ability to have win-win scenarios between the patient, the provider, and the payer, such that if we work together, we can decrease cost and improve quality. And in fact, this is the vision of value-based care. It's the vision of the ACA and of MACRA, and we're falling very far behind because we're really not we're not making much progress in American medicine in providing value-based care. I hope I explained that adequately, what an alternative payment context is.
No, I get that. We're on limited time, but thank you all so much for being here today. It's very valuable, so thank you. And Chairman, I yield back.
Dr. Wenstrup.
Thank you, Mr. Chairman, and thank you again for being here, all of you. You know, I think one of the frustrating things for physicians today, I can remember practicing 80s and 90s, and the headlines every day were greedy doctors this and greedy doctors that, and I was so far in debt that as I'm starting up in my practice, that I was like, you got to be kidding me. Do you know how many years went into this debt? And while my friends were out making money and having a good time, as their careers were starting off, I was further and further in debt. And that's where doctors are today, $200,000 in debt and all this stuff. And then you come out into an environment where you must be out to try and rip people off. And the fact of the matter is you set aside and work very hard for 7, 10 years, sometimes more depending upon your specialty, and this is what you face when you get out. And I don't think that's going to help the future of medicine and that's why you see so many doctors today telling their kids, don't go into medicine. I went to court one time in 27 years in practice, and that was to testify against another doctor. Because what that doctor was doing wasn't just bad outcomes, it was bad things. And we want to police our own. And so when you get into all this and everybody's guilty until proven innocent of something, we've really harmed our system. And I think with today, the way you can collect data and outcomes, you can come up with alternative payment models. And you can look at trends. The community knows who's not doing things right. I promise you. As a doctor, I never felt I needed Washington to tell me if I was doing a good job. I needed my referring doctors to tell me that. I needed my patients to tell me that. And that's how I kept my doors open, and that's how I was able to put a roof over my head. So we're going in the wrong direction here. I'm all in favor of going after bad actors, but don't make everyone a bad actor. And our system is in that situation today. And so I kind of address that to you, Ms. Silva, because you're in that arena, and aren't there ways we can do this better where we can, like I said, communities know who the bad actors are. I think we could cut your agency down considerably and do more. Yeah, if you don't mind addressing that, please.
Yes. Thank you, Congressman Wenstrup. I I think we'd all like to live in a world where all doctors are as you describe, and I do believe that there are many such doctors who go to medical school and try to do the right thing by their patients. But if the Department of Justice were here today, I think they give you many, many examples of doctors who don't fit into that category. There are doctors who violate the anti-kickback statute. There are doctors who engage in abusive practices. There are hospitals that engage in abusive practices. And the Stark Law isn't assuming that everyone's a bad actor, but it is directing all healthcare providers to stay away from an area which is prone to abuse. And the anti-kickback statute is designed to ensure that people who actually have the intent to influence decision-making are covered. So, we'd like everyone to be appropriate, but the laws are designed for those who are not.
Now, the kickback statute, I get that, but at the same time, I think with today's ability to collect data and watch things, we can watch for trends and then go after the people that are abusive.
Thank you. On behalf of the subcommittee, thank all four of you for your testimony today. I just want to hit a couple of just quick points. Ms. Sylvia, I hear what you're saying. So I know you're the minority witness, and I know you feel like, oh, golly, 3-1 and all that. But I hear what you're saying, and at least my attitude, and I think I speak for most folks on the committee, there's not this disposition that says, let's just sweep this away, like it's all a foregone conclusion. But it really does feel like we can improve this. And I'd be interested in your thoughts and in terms of improvement, your thoughts on, for example, Mr. DeBusk's suggestion on codification of the exemptions and so forth. That seems to me pretty rational. So I think that there's some very good work that we can do here. My view, you and I would probably differ in terms of strict liability. You've articulated a reason for it. I think that it's, I think it's maybe yesterday, and moving more into intent is the way to go. And I get it, reasonable people can differ. The harmonization of, and this was the testimony of Secretary Hargan, the harmonization essentially of the anti-kickback statute with Stark, these things should be, the terms of art should be overlapping, they should be interactive and so forth. And I think this is something that we can take up. The final point is there's good work that we can do here. So God bless my friend, Mr. Levin. But when Mr. Levin says, I'm so disappointed and bummed out that we're having this conversation now as opposed to previously, it's like, okay, I get that, but we're having this conversation now. And I think that is a good thing. And notwithstanding some of the other, disagreements we have about the ACA and so forth, I think that this subcommittee can do really robust, solid work that can take into account the critics like Ms. Sylvia, who are basically urging pump the brakes here, don't go too fast, and yet at the same time are sensitive to the changing nature of things. And I think that we can perform at a higher level on a bipartisan basis, and I'm looking forward to fruitful work. And I sense I've provoked Mr. Levin, and I will yield to him.
I fully agree.
I continue to yield to him.
I just regretted so much that it's July and we're now discussing this constructively when we should have been doing it all along. But I agree completely that this is an example of where we need to sit down and exchange ideas. I agree completely.
Well, I'm not going to improve on that closing. And as a reminder, any member who wishes to submit a question for the record will have 14 days to do so. If any members submit questions after this hearing, I ask that the witnesses would respond in a timely manner to the extent that you're able. And with that, again, thank you to our witnesses. The committee stands adjourned.
We were cannon fodder.
someone survived.
Yeah, we don't have a really good story. I think we were meant to be blown up. It's nice to meet you. And you were